Sir, we can start, sir.
Okay, thank you. Very good evening to all. I'm Dr. Suman. I'm a diabetologist and I'm the secretary of AOHK Bangalore. And today we are doing the 101 issue of Enoch Connect webinar. This is one of the very important webinars which has been happening since a long time. This is a knowledge sharing platform wherein they try and share different the topics are related to occupational health, related to other medical parameters. Today we have with us Dr. Amrita Chakrabarti, who is going to talk about the clinical updates in the chronic myeloid leukemia. Just to give a few updates about Dr. Amrita Chakrabarti. Dr. Amrita Chakrabarti is a consultant hematologist. She's an hemato-oncologist and a bone marrow transplant and surgeon, means a specialist who's been working in Max Super Specialty Hospital at New Delhi. In fact, Dr. Amrita is a well-known oncologist, and she's been practicing in Supermax Hospital since a long time. From past 10 years, she's been working as a blood cancer doctor and gaining the proficiency skills and knowledge in the segment. In fact, she has pursued her MBBS and MBA from National Board of Delhi. And also she has done some treatment offering the Amrita Blood Case Cancer Treatment Center. And also she's a member of Royal College of Pathologists. In fact, she has got a special interest in the stem cells transplantation, autologous and allologous plant, and she has also done malignant hematological conditions like acute and chronic myeloid leukemias, and also she's been a benign blood disorders. She's also been one of the part of that. So it is very happy to welcome Dr. Amrita. I just invite Dr. Amrita to take over and just tell us about the clinical updates on the chronic myeloid leukemia. Over to you, ma'am.
Thank you so much, sir. Thank you for the kind introduction. And we are going to be talking about chronic myeloid leukemia, CML. It's a pretty interesting topic, and we do have a lot of updates, lots of things to talk about this particular topic. We have plenty of wonderful medications available in the market which were not there, say even 10 years, 15 years down the line, and then earlier on in the decade and or maybe like 10, 15 years back, the only options for somebody with CML used to be going for very toxic chemotherapies and maybe a bone marrow transplant. So with the introduction of tyrosine kinase inhibitors or TKIs, the whole scenario has changed, and we have some very good TKIs available for us. The first generation, second generation, third generation ones. And like we will see in our presentation, these TKIs have drastically changed the entire concept of treatment. And now with the introduction of TKIs, the overall survival and the event-free survival has improved to a large extent. So what is CML? We all are well aware of what chronic myeloid leukemia is. CML is basically a clonal myeloproliferative neoplasm, and it originates in the pluripotent hematopoietic stem cells. And these cells in the marrow, they undergo inappropriate or uncontrolled clonal expansion, which causes rapid proliferation of these cells in the marrow. And then eventually they spill over to the peripheral blood. And we can see a lot of myeloid cells in the peripheral blood. So this is CML. Now, the definition of CML per se is that all CML should have the BCR-ABL1 chromosome, or the translocation of 922, which we call the Philadelphia chromosome. Now, this is the hallmark of CML. So if the BCR-ABL1 or T translocation 922 is not present, we will not term it as CML. We can term it as an atypical CML or something else. I mean, then we look for other mutations and maybe they become a part of other myeloproliferative disorders. But the hallmark of CML is the fusion of BCR-ABL1 gene or presence of 922 translocation. Now, like we were saying, that there is this myeloid burst in the bone marrow. A lot of myeloid cells get proliferated in an uncontrolled manner. So what basically happens is they replace the entire marrow architecture, the structure or the architecture with these rapidly proliferating myeloid cells, myeloid lineages, and in the peripheral blood also, we can find different kinds of all stages of maturation of neutrophils. We will find neutrophils, we will find the band forms, the myelocyte, metamyelocyte, promyelocyte. So there is a left shift, and along with this, we can also find an increase in basophils or eosinophils. Now, this is very interesting because usually people who have a lot of infection or people who are septic, they show a similar picture in the blood. There is a huge left shift, and the cell count increases, and lots of neutrophils and left shifted cells, the band forms and immature forms of myeloid series are seen. Then how do we differentiate between these two? So this is just out of our present topic of discussion. This is just for the general information. So basically, if you just see the peripheral smear, the first thing you will notice is in CML, we more often than not, almost always, we will find an increase in basophils and eosinophils, or basophil or eosinophil, and sometimes both. But this particular feature will not be present in septic patients or patients in whom the cells have increased because of a reactive process. So that is called a leukemoid reaction or a leukemia-like reaction. That is not actually a CML. That is just a reaction to the sepsis or the overt infection, which eventually goes down on its own when we treat the infection with antibiotics, etc. So later on comes the molecular part of actually diagnosing it, finding the BCR-ABL1 mutation or the Philadelphia chromosome. So that comes later. So a good pathologist, just by seeing a blood smear, can tell you there's a myeloid bulge, there is an increased amount of myelocytes, and there will also be these background increased basophils and eosinophils, and obviously the features which you find in a toxic person, in a person in whom the blood, the WBC has increased because of an infection, you can find certain toxic changes in such people which will not be seen in CML. So what happens when the BCR-ABL, when there is a mutation in the tyrosine kinase gene, so the tyrosine kinase activity, so there is uncontrolled proliferation because of an upregulation of the TKI or tyrosine kinase activity. So what happens, we've already discussed, there is an increased uncontrolled proliferation of these myeloid cells, and these cells, there is a decreased apoptotic response, which means these cells are resistant to dying. They stay alive and they proliferate in an uncontrolled manner, which results in an overproduction of these myeloid cells and these premature cells, and which eventually gets spilled into the peripheral blood. Right. Can we have the next slide? All right. So CML, basically, whenever we are talking about CML, we say it is a triphasic disorder, by which I mean that CML has basically 3 stages: the chronic phase, the accelerated phase, and finally the blast crisis phase. So the chronic phase, majority of the patients coming to us, we diagnose in the chronic phase. So what happens in the chronic phase is that the blast cells are not very high. So the peripheral blood will show only, say, around less than 5% of blast cells. Then the accelerated phase and the blast phase is when patients are not diagnosed or treatment is not commenced, or somebody has a treatment failure or default. Say somebody has been diagnosed in the chronic phase, they start taking a tyrosine kinase inhibitor, and then they stop treatment, or somebody has not been diagnosed. So then the disease eventually, it progresses to the accelerated phase and the blast phase. Now, there are two different diagnostic criteria for accelerated phase and the blast phase. Now, there is the ELN criteria and the WHO criteria. ELN says that accelerated phase, the blast cells should be between 15 to 20%, and the basophil percentage should be more than 20%. There should be thrombocytopenia, by which I mean that the platelet count should be less than 100, and there should be clonal cytogenetic abnormality in the Philadelphia positive cells, or a major route abnormality while on treatment. Now, again, the ELN criteria, which you're seeing on the screen, is the WHO, the ELN one. We'll talk about the WHO one as well. So the ELN criteria for the blast crisis phase is that there should be, I'm sorry, I already said the blast crisis will be around 15 to 20% cells. Now, for the blast crisis for ELN will be that the cell should be more than 30% in the peripheral blood or in the bone marrow, and there should be deposits of extramedullary blast cells. This is according to ELN. Now, according to the WHO criteria, in the accelerated phase, there is 10 to 19% of cells in the peripheral blood. Again, there should be more than 20% of basophils. There can be thrombocytopenia, which is less than 100 platelets, or thrombocytosis, which is more than 1,000. There should be clonal cytogenetic abnormality, or Philadelphia positive cells, or in patients who are already treated. There should be an increasing spleen size, and the WBCs should be unresponsive to treatment, and they should be on an increasing trend. Now, WHO criteria for blast crisis says that the blast cells should be more than 20%. There should be extramedullary blast proliferation, which excludes the spleen, and there should be large clusters of blasts found in the bone marrow. So if either of these criteria are satisfied and the percentage of cells is more than 20, so then it is a blast crisis as per the WHO criteria, while more than 30% is required as per the ELN criteria. So next slide, please. Now we'll come back to this slide. We'll just skip a couple of slides and go to the scoring system first to understand that. And then we talk about the therapeutic strategy. Can we have the next slide? The next one. Okay, so this is the scoring system of CML. Now, this is basically, we are using the scoring system when we're talking about the chronic phase of the CML. So we have the SOPL scoring system that has scored UTOS and ELTS. We do not need to remember how it is calculated, the entire formula, just the variables which are considered in this condition. So we consider the age, the splenic size, the platelet count, the basophil count, eosinophil count, and the peripheral blood blast percentage. So these are basically the variables which are included, and using these, putting in one of these formulas, we calculate the scoring system. So we use the ELTS, the SOPL scoring system. Whenever we have a patient who comes for the first time, to see whether the patient falls under the high risk category or the low risk category, because that determines the life expectancy. Also, it helps in choosing what kind of treatment we should give to the patient, whether we should start with the first generation or a second generation one. So now we'll go back to the slides that we skipped, please. We'll go back. Yes, all right. So then talking about the therapeutic strategy. Now, before we talk about the therapeutic strategy, I think it is fair that we should discuss a little about the investigation and the clinical features of CML. Now, a person who has CML, initially they can be completely asymptomatic. There are no symptoms at all. Now, the majority of patients that come to us, they usually come to us with fatigue, with a fullness of, a full sensation of the abdomen. There's early satiety. They feel full after eating a small amount of food because there is progressive splenomegaly. The spleen increases its size, which causes this early satiety. And also they can be having frequent infections, and they can be having fatigue and some non-specific symptoms. Now, these symptoms can also be there. By these symptoms, I mean, weight loss, sweating, loss of appetite, and obviously organomegaly, by which splenomegaly is there, so which is the most important feature. Now, basically, so the symptoms that we see in a CML will be, just summarizing. So it is a fatigue, night sweat, malaise, weight loss, left upper quadrant pain, which is because of splenomegaly. And again, some less frequent features can also be seen, but nevertheless, these should be investigated, and CML should always be kept in mind. The less common features can be because of leukostasis. Now, we all know that CML patients can have very, very high WBC counts. The WBC counts can increase, exceed 2 lakhs, 1.5 lakhs, 2 lakhs. And such patients tend to develop leukostasis. So some of the features of leukostasis can be retinal hemorrhages, then priapism, then there can be bone pains because of infarction of the bone, and sometimes there is a skin infiltration of these leukemic cells. There can be skin nodules or small masses in the spleen. There can be extramedullary mass, in the soft tissue and skin also, and also there can be hepatomegaly. So these are some of the common features. Now, evaluation of CML. So before we get down to these molecular tests and we talk about FISH and karyotyping and RT-PCR, we start with a simple history and a simple examination. Now, obviously, whenever we suspect CML, first of all, a full history is very important. We should talk about the occupational history, any history of exposure to carcinogens, any family history, and potentially it is important that we identify what siblings are there, and so that in the future, if we ever need to think about a bone marrow transplant, we have all the information handy with us. Do a physical examination, see whether there is an increase in liver or spleen size, and see if it is there, then how big it is, how far below the costal margin it is going, and again, you do some scanning, you do an ultrasound to see the spleen size, you do some routine biochemistries, the LFTs and KFTs and LDH. LDH is expected to be very high because of rapid cell proliferation and turnover, and the uric acid. Obviously, you will do a peripheral smear and a full blood count. We also need to check the viral markers, and then comes the bone marrow. The bone marrow is very important, even if the peripheral blood and the molecular tests tell us, confirm us that it is CML, because the staging of CML is usually done. We just saw the criteria of accelerated phase and blast phase, and the percentage of blasts. Sometimes it is very important to determine how much percentage of blast is there in the bone marrow. Now, the peripheral blood may have a small amount of blast, and you may miss whether it is in the accelerated phase or the blast crisis phase or in the chronic phase. So it is very important to always undergo a bone marrow examination and see what stage the patient belongs to. You count the number of blasts in the bone marrow. Then obviously you can run a flow cytometry, do an immunophenotyping to see the CD34 cells and the blast cells. If you have a doubt in differentiating them in morphology, then obviously we do the BCR-ABL test by RT-PCR. You can do it by FISH also. Now, 95% cases, the BCR-ABL1 will come positive when we do it by, conventional RT-PCR. Sometimes, in 5% cases, these translocation may be cryptic or hidden. So in those cases, a FISH can be helpful, or a karyotyping. We can do a G banding also, and they can help us know whether there is a cryptic BCR-ABL1 or Philadelphia chromosome, which is not seen in RT-PCR. Then, if you suspect a patient has progressed to the blast crisis stage, it is very important that you characterize the kind of blast, whether it is a myeloid blast or a lymphoid blast. Now, CML can progress into either ALL or AML. Then, if it is an ALL, if you diagnose a ALL blast crisis in a CML patient, it is important that we do a lumbar puncture to see whether there is any dissemination of the leukemic cells in the CNS, because we all know that ALL has a high propensity to disseminate into the CNS and the CSF. Again, there's one more thing I would like to mention over here, is that a lot of patients that we find of CML are young. Now, it is important to address the fertility issue in these cases. And it is important that when you diagnose a patient with CML, before we jump onto treatment, it is very important that you sit and counsel the patient, and also you tell them about sperm banking or preservation of the ovum. In case you are planning to start treatment, we will get to know the implications and of the TKIs and other treatment later on in the slides. So, and obviously, very important, you calculate the score, the so-called score or the ELTS or the UTOS score, because you want to know in which category the patient falls, so that you know exactly what treatment to give. The mutation analysis, we do not do it in the first go. So when we start treatment initially, if the patient is not responding, or if the initial response is lost, then when we suspect a mutation in the T315I, or which is the tyrosine kinase domain mutation, TKD mutation, then we go for a mutation analysis. So not initially. Can we have the next slide, please? Okay, so coming to the therapeutic strategies. So like we all know, the entire scenario of treatment of CML has undergone a vast upheaval, a vast change, a change for good with the introduction of the tyrosine kinase inhibitors. Initially, we had imatinib, which is the first generation TKI. Then we have the second generation TKI, which is the nilotinib, dasatinib. Well, bosutinib and ponatinib can be called the third generation. We do not usually use it in the first line, hardly. Ponatinib is not available in our country. So, and again, asciminib, this is a newer drug and it is still in the trial phase. And this is basically an allosteric inhibitor of the BCR-ABL. Now, asciminib, we'll talk about it later, but this can be used as a single agent or in combination with other tyrosine kinase inhibitors. We usually use asciminib in which prior lines of TKI therapy has failed, 1 or 2 lines of TKI therapy has failed, or when we find a T315I mutation, which is a tyrosine kinase inhibitor mutation, receptor mutation, and in which other first or second generation TKIs are not functioning, are not working, then we can use asciminib. Now, the important question over here is, since we have so many options available in front of us, what to go for, what to choose? Now, again, first of all, in a country like India, money is an issue. We have to consider the financial aspects, which again, definitely, while it plays an important role, we have to the other most important factor is to consider the side effects, to consider which drug would work for whom, and when to start, a first generation TKI, or when can we introduce a second generation TKI, when can we directly start with a dasatinib or nilotinib and skip imatinib, in which patients you should actually use imatinib and you should refrain from the others. So that is very important. Now, before you decide which drug to choose, I think it is important that we familiarize ourselves with some of the common side effects of the TKI inhibitors which are available in the market. So imatinib, basically, it has a lot of GI side effects, and patients can have, besides nausea and increased dyspepsia. So a lot of patients on imatinib usually we can see a prolong in the QT interval. So yeah, people with cardiac conditions, we have to be careful about imatinib. And again, it should be used carefully in people who have hypertension, any ischemic heart disease, cardiovascular diseases, diabetes, or GI bleed. Although these are just, not complete, absolute contraindications. These are intermediate contraindications. And honestly speaking, in whichever patients we have treated with imatinib, we do not see a lot of these side effects. So, however, they have been documented and we have to be cautious about them. And then coming to nilotinib. So in nilotinib, again, intermediate risk categories would be patients with hypertension, diabetes, congestive heart failure, people with abnormal liver function tests. However, an absolute contraindication of nilotinib is patients who have an increased QT interval at baseline. So patients having cardiac conduction abnormalities and all, and increased QT interval, in such patients, nilotinib should not be introduced. For dasatinib, again, the intermediate, risks would be, again, diabetes. But however, we have to be absolutely careful about patients with lung diseases, pulmonary diseases, and pulmonary hypertension and effusions. So if somebody has a pleural effusion or a pericardial effusion or a pulmonary hypertension, in such patients, dasatinib is completely contraindicated. Bosutinib, again, I think basically we look for any GI symptoms in patients with active peptic ulcers, where history of GI bleed, and any abnormal liver function tests. And asciminib, well, we don't have much data yet regarding it, but some of the common side effects of asciminib will be some musculoskeletal pains and nausea, and again, bony pains. So these are basically some of the common side effects of asciminib. So can we go on to the next slide, please? Okay, we've talked about the prognostic scoring. Next. Now, like we were talking in the earlier days, the only options used to be very toxic chemotherapy regimens or an allogenic bone marrow transplant. If a suitable donor was available. However, the overall survival or the event-free survival of such treatment has not been very high. We will, like these, we'll see in the coming slides, when we compare them to our current tyrosine kinase inhibitor therapy, these patients did not have a very good overall response rate or overall survival. And not to talk about the toxicities and the side effects of chemotherapy. So nowadays, definitely when a patient comes in a chronic phase or even in an accelerated phase, we do not talk about chemotherapy. However, allogenic bone marrow transplant has to be kept in mind, and right on diagnosis, we should see the sibling status, and then I think it is very wise to get a HLA typing done of the patient and the siblings right on treatment, because we never know, even in the future, in case we do need to think about an allo transplant, at least we will have all that information handy. Now, patients who present in a blast crisis stage, in such patients, again, I think now the only treatment will be patients who present in blast crisis stage, they have to be treated as acute leukemias. Now, blast crisis can be an acute myeloid crisis or a lymphoid crisis. Now, CML patients in blast crisis can convert into either AML or ALL. Now, in such patients, definitely we need to think about chemotherapy. So the regimen of choice that we give is FLAG-IDA. It's a pretty toxic regimen. So obviously we need to do proper workup before introducing such a regimen. Now, if somebody has has ended up with an ALL or a lymphoid blast crisis, we can give the same chemotherapy that we give to ALL patients. Now, along with this, it is important that we introduce the tyrosine kinase inhibitor, especially if the patient has been a tyrosine kinase inhibitor naive patient. It has never been used in such a patient. We prefer dasatinib for patients that who have progressed into accelerated phase or the blast crisis phase, and the only reason is that dasatinib has shown to cross the blood-brain barrier, and which is not the case for nilotinib. Imatinib can be used in a higher dose for an accelerated phase, but studies have shown that such patients usually relapse within 2 years. So right now, what I would say is that dasatinib would be the treatment of choice if a patient has converted from a CP to an AP or a BC. Along with in BC, obviously, we have to go for chemotherapy. And then once the patient is in remission after we introduce chemotherapy, be it a FLAG-IDA or treatment for AML or AML, whichever regimen you choose. And then once the patient is in remission, it is important to go for a allogenic bone marrow transplant, because the prognosis of such patients is extremely poor without a transplant. Next slide, please. Okay, so well, when we compare imatinib with combination chemotherapy, by combination chemotherapy I mean conventional chemotherapy and maybe interferon alpha, we see that the progression-free survival is much higher in patients with imatinib, and over here we are just talking about the first generation TKI, which is imatinib. So even with the first generation TKI, once imatinib was introduced in the market and it was started on patients on CML, we have observed that the progression-free survival is much more compared to combination chemotherapy. So nevertheless, these days, every patient is switched to a TKI, and none of the patients, no patient who comes to us with an initial diagnosis of a CML in a chronic phase or even an accelerated phase, receive combination chemotherapy. Almost everybody gets a tyrosine kinase inhibitor, be it imatinib or a second generation. Next slide, please. So again, this is the same thing. So this is the major cytogenetic response, which is by we will talk about the major cytogenetic response and the major molecular response and all in a while. So this is the amount of Philadelphia chromosome which is decreasing. So complete cytogenetic response, or the major one, is when we find zero Philadelphia chromosome in the peripheral blood. And so this is the achievement of the major cytogenetic response, or the Philadelphia chromosome disappearing with imatinib is much, much higher than we do with conventional chemotherapy. So conventional chemotherapy can include, cytarabine along with, other agents, including interferon alpha or maybe daunorubicin. Next slide, please. Okay, so when we are talking about imatinib, now, imatinib is the first generation TKI that was initially introduced in the market, and obviously, it is the recommended first-line treatment for majority of adults and children with CML who present in the chronic phase. And so, like we discussed before, all patients before we start imatinib, they should undergo a baseline assessment with an ECG, a lipid profile, and a fasting glucose, HbA1c, and other cardiovascular risk factors. And obviously, along with that, a viral marker profile, the hepatitis B, hepatitis C, and again, the risk scoring system before we decide whether the patient is a good candidate for imatinib or dasatinib or nilotinib, whichever TKI we choose. Now, I would just want to talk about when to introduce imatinib and when to introduce dasatinib or nilotinib. Now, I personally prefer patients to be started on imatinib in most of the cases, by which I mean patients who are elderly, basically. Now, patients presenting in their 50s or 60s or even 40s, now patients who have completed their families, who usually have a lot of side effects or comorbidities. We prefer starting with imatinib. It is more cost effective. The side effect profile is much lower. And we have seen that patients on imatinib, in 10 years, they eventually reach the same, deep molecular remission, or maybe, an MR4. They can reach that by 10 years. Now, when second generation TKIs are concerned, like nilotinib or bosutinib, nilotinib or your dasatinib, we prefer these when either the patient is a young patient and we are thinking of, stopping the patient, stopping the drug after some time, which is the TFR, or the treatment when we are trying to attempt the treatment-free remission period. We'll talk about TFR in a while. So when we decide that the drug needs to be stopped after a while. So mind you that imatinib, when we start imatinib, it has to be continued indefinitely. So maybe, much beyond 5 years, maybe 10 years, or sometimes lifelong. Now, if patients are young and they want to start a family, and eventually we are looking at stopping the drug at some point of time, I think it is better to go for a second generation TKI rather than imatinib, because with nilotinib and dasatinib, usually we can attempt a treatment-free remission after 5 years of treatment at least, if the patient has achieved a deep molecular remission or MR4. Now, the second point is if in cases of young women who want to start a family. Now, tyrosine kinase inhibitors are not seen to be very safe in pregnancy. And obviously, these agents need to be stopped at least in the first trimester, preferably in the second and third. But trials have been done and patients have received these drugs, the TKIs, in the second and third trimesters, and not much adverse effects have been seen. But if a woman wants to plan a family and they want to achieve a TFR or a treatment-free period, then I think it is better to go for a second generation one rather than a third generation one. Now, the third one, I think patients who initially present with a very high Sokal score or a high risk disease, the risk of such patients eventually progressing to an accelerated phase or a blast phase is much higher compared to patients who have a low Sokal score. So patients having a high score, again, my choice of treatment will be a second generation TKI rather than imatinib. So these are basically the main limitations of imatinib. Again, when we look at the response, Second generation TKIs, the achievement of uh, major cytogenetic response or a complete cytogenetic response, or even an MMR, the major molecular response, is much higher compared to that we see in imatinib. However, well, I would say personally over here that I have treated patients with imatinib, and we do monitor them every 3 monthly initially. The response I have noticed with imatinib is comparable to second generation TKIs in most of the patients. So unless we have somebody who has a very high risk disease, or somebody in which we need to stop the medicine, we are thinking of stopping the medicine, I think why not go for imatinib? Or somebody has, usually we have a lot of older patients with a lot of comorbidities, heart conditions and lung conditions. And we know that, people with dyslipidemia and diabetes. So in such patients, it may not be safe to go for a second generation TKI. And obviously, cost being another factor, second generation TKIs are much more expensive. So we start with imatinib in such patients. Okay, next slide, please. So I don't think we need to go much in detail about the mechanism of resistance of imatinib. So basically what happens is there is a tyrosine kinase domain mutation, which happens with imatinib. And, if that happens, again, we need to go on to the third generation TKI, which is ponatinib. And other than that, there can be other mutations. There can be, acquisition of, uh, you know, other molecular mutations, or secondary mutations, which can cause a loss of mechanism reaction to, or TK to imatinib, or resistance to imatinib. So, okay, next slide, please. So how do we overcome this resistance? So there are two things we can try. So initially we start imatinib with a dose of 400 milligram once daily. What we can do is we can slowly increase the dose of imatinib and see whether such patients are responding better. So after 3 months, if a patient comes with absolutely no response after 3 months of treatment with imatinib, then I think it is better to completely switch to a second generation TKI. But if there has been a partial response, then I think and if there is not much of side effects and patients are able to tolerate 400 milligrams of imatinib, I think it is fair to increase the dose of imatinib to maybe 600 milligrams once daily, or maybe 800 milligrams once daily, and see whether the patient is achieving the milestones that we look that we think that they should be achieving. If not, then again, after 3 more months of therapy, I think it is better to go for a second generation TKI. So either whenever patients come with resistance to imatinib, either we can increase the dose, or we can directly switch to a second generation TKI, which includes dasatinib or nilotinib. Now, patient preference over here definitely plays a big response. Well, before we talk about the second generation TKIs, I would just like to mention over here, we have been talking about the CCYR and the MR1, MR2, the MR3, MR4. What exactly are these? So just summarizing this very shortly, after 3 months, initial 3 months of treatment with a tyrosine kinase inhibitor, we expect 1 log reduction in the BCR-ABL1, which we measure as per the international scaling, or BCR-ABL1 IS. There should be 1 log reduction in that after 3 months of therapy, by which I mean that the BCR-ABL1 IA should fall below 10%. Now that is MR1, in which the BCR-ABL1 is 10% or below. So that is MR1. So after 6 months of therapy, after 3 more months, there should be 2 log reduction in the BCR-ABL1 by IS. So the BCR-ABL1 IS should fall to 1%. So that is MR2. Again, MR3, or which is also called as the MMR, or the major molecular response, is when the BCR-ABL1 IS is 0.1, which is 3 log reduction. Now, the fourth one is 0.01% of BCR-ABL1. This is called MR4, or deep molecular response. So MR4 or less than equal to 0.01% is the deep molecular response. It is very, very important that the patient achieves deep molecular response of 0.01%, less than 0.01% BCR-ABL IS, in order to think about stopping the tyrosine kinase inhibitors, or attempting a treatment-free remission period. So achievement of this TFR is much, much higher when we go on to the second generation of TKIs. Can we have the next slide, please? So achievement of this deep molecular response, or MR4, is much higher in a much shorter period of time when we use dasatinib or nilotinib rather than imatinib. Although studies have shown that it is possible to attain this MR4 with imatinib, which is the first generation one, in around 10 years' time. So if you want to wait for 10 years and the patient is tolerating it pretty well, then maybe we can give a trial of 10 years of imatinib. Otherwise, it is better to switch to a second generation of TKI. Now, second generation, we are mostly talking about dasatinib and nilotinib over here. Okay, so dasatinib is, I think we can skip this one, basically. The mechanism of action is basically that when it acts on the tyrosine kinase domain, and then it causes a downregulation of the tyrosine kinase domain, and causes decreased proliferation of cells and helps in faster achievement of a MMR or a complete cytogenetic response. So basically, the mechanism of action of both first and second generation TKIs are the same. It's just that the efficacy differs between the first and second generation, and the time to response differs. So it has a greater affinity for the domain compared to imatinib, which explains the greater efficacy of dasatinib compared to imatinib. Next slide, please. Okay, so when do you give dasatinib? Well, dasatinib can be given as second-line drug in patients who have initially got imatinib, and such patients have not responded well, and there has been inadequate response. We can switch to a second-generation TKI after obviously reviewing the side effect profile of the patient, the comorbidities and all. So it can be used as a second line first. Now, the second indication, we can also go for dasatinib as a first-line therapy. Now, without introducing imatinib in the first place, I have already talked about when to consider dasatinib or a second-generation TKI as a first-line therapy. So one is in younger patients in which we are trying to think about achieving a TFR. Second is in high-risk patients, the risk category being calculated by the Sokal scoring, the Utah scoring, etc., ELTS. The third is in women who wish to start a family. And so in these three patients, basically, I think dasatinib would be a much better choice compared to imatinib. So next is the dosage. Okay, this is very interesting over here because what we usually do is now another thing, I'm sorry, I skipped dasatinib again. Another indication is when a patient has progressed from a chronic phase to an accelerated phase. Now, whether the patient had been on imatinib or nilotinib, now for accelerated phase, the indication is always dasatinib. So we do not give nilotinib in a patient who has an AP. We can try to give imatinib in a higher dose, but dasatinib is much more preferable. Why? I've already spoken about this, because it penetrates the blood-brain barrier, and so which is not done in case of nilotinib. So dasatinib, the indications are either a first line or a second line, or in patients who are progressing, right? So dasatinib can be given as a 100 milligram tablet once daily. However, we have seen studies. The studies which have conducted have shown that there is actually no difference in the overall efficacy when dasatinib is either given as a 50 milligram tablet once daily or 100 milligram. So actually, when you give a 50 milligram, maybe the side effect profile is much lower and it is much easier to tolerate. So a lot of doctors right now have introduced dasatinib as 50 milligram tablet once daily compared to 100 milligram. So again, if the patient is tolerating it pretty well and the patient has come with a high burden of disease, maybe I would personally start with 100 milligram once daily. However, if we see that the patient is having difficulty to tolerate, and maybe we can give a trial of 50 milligram and see. Now, for accelerated phase patients presenting with CML-AP, the dose would be 140 milligram daily. We can give it in 2 divided doses. We have 70 milligram dasatinib available in the market. So dasatinib is usually given, obviously all tyrosine kinase inhibitors are oral formulations. None of these are injectable. So we can give it with or without meal. We usually advise patients to take it right after lunch or after dinner. So yeah, that is the mechanism. That is the way that we give dasatinib. Now we have spoken quite a bit about well, dasatinib and imatinib, and well, their mechanisms of action and their efficacies and all. So the Dasian trial that has been done, so basically most of the data comes from this particular trial. It compares directly dasatinib to imatinib and shows efficacy in terms of overall survival and event-free survival. When we compare both these drugs in newly diagnosed patients or who are TKI naive patients. So can we have the next slide, please? So yeah, so patients should be treatment naive, which I mean that patients should be newly diagnosed in CML chronic phase and should not have received any prior treatment with any other tyrosine kinase inhibitor, and the patient should be diagnosed within 3 months. So these patients were divided into two categories. One group received dasatinib 100 milligram once daily. The other group received imatinib 400 milligram once daily. So basically, what we were trying to determine over here was the achievement of complete cytogenetic response by 12 months of therapy. And so complete cytogenetic response again is when there is no Philadelphia chromosome, which is detectable in the peripheral blood, or Philadelphia chromosome is 0. Next slide, please. Right. So these data over here show that imatinib, compared to imatinib, obviously, dasatinib, the percentage of patients achieving a complete cytogenetic response is much higher. And by 12 months, and again in 18 months, when we compare both these drugs, in patients on dasatinib, a larger number of patients on dasatinib have achieved a complete cytogenetic response compared to patients on imatinib. Next slide. So this study concludes that with longer follow-up, dasatinib continues to demonstrate superior efficacy compared to imatinib in patients with CML chronic phase. And well, the achievement of CCYR and MMR is much higher and much faster in patients introduced on second generation TKI dasatinib compared to imatinib. However, and fewer patients transformed to AP or BP in either group. And however, I would like to mention over here, like I said, that patients who initially present with a higher scoring system, higher risks, they are more prone to developing, to transforming into AP or BP if they are kept on imatinib. So it is always better to start them on dasatinib or nilotinib. So dasatinib continues to be generally well tolerated. However, like I said before, patients, we have to be very cautious about introducing this drug on patients who have pulmonary hypertension or a chronic lung disease in chronic smokers, patients who have pleural effusion. And so we generally avoid dasatinib in such patients. And based on the predictive value of early complete cytogenetic response, further follow-up may demonstrate better long-term outcomes, such as progression-free survival or overall survival for first-line dasatinib versus imatinib. So in any case, obviously, a second-generation TKI is said to be much better compared to a first-generation TKI. Next slide, please. So this is again another study which compared dasatinib 100 milligram versus imatinib 400 milligram in newly diagnosed CML-CP. So this is just another one compared to the Dasian trial, the same one, the SO325 trial. So again, it's the same primary endpoint. We are seeing the BCR-ABL transcripts over here, at 12 months, and whether there is a more than a 4 log reduction, and the time point, whether the achievement of 4 log reduction or achievement of a deep molecular response or DMR was done within 12 months. And in compared in how many patients the DMR was achieved within 12 months in dasatinib compared to imatinib. Also, this particular study, determined the cytogenetic response by 12 months and the best hematological response by 12 months, along with adverse effect profile, obviously. So comparative expected data where we see that achievement of 3 log reduction or MMR3 was achieved in a higher percentage of patients in dasatinib compared to imatinib. Same 4 log reduction, higher percentage of patients achieved a 4 log reduction or a deep DMR, deep molecular response compared to imatinib. And cytogenetic response is again higher, and hematological response, well, response within 12 months, we see This one is, marginally almost comparable in both the patients. So by hematological response, I mean is the decrease in the peripheral blood WBC counts. So these are pretty much the same in both imatinib and dasatinib. Almost all patients presenting with a very high WBC, their counts go back to normal. The thing over here, the basic thing over here, the most important thing over here is whether there is achievement of molecular response or not, and if yes, then and how much longer and how deep is it? And again, progression-free survival is almost comparable between both these drugs. It's marginally higher in second generation compared to the first generation. Next slide. So the authors conclude, again, I think it is the same conclusion that we have compared to the previous one, that dasatinib appears to be more efficacious than imatinib for patients with treatment-naive chronic phase CML. And dasatinib and imatinib have different toxicity profiles. We have spoken about the toxicities a little, and imatinib, again, more of GI side effects, more of yes, fluid retention, nausea, and dasatinib is more of thrombocytopenias and fluid effusions. However, patients with imatinib also have a lot of cytopenias. Usually, when it started initially, the first 3 months of therapy. Now, whether a patient is receiving a first generation TKI or a second generation TKI, we usually see a lot of cytopenias. And a lot of patients, obviously, along with the cytopenias, they have this nausea and the fullness and complete loss of appetite. They tend to stop the medications on their own, which is a very, very risky thing to do, because these are the group of patients who eventually end up with a AP or a BC. So it is very important when you're treating a patient with CML, you have to reinforce again and again that such patients do not stop their TKIs. And even when they are having a lot of side effect profile, they should come to their doctor. It's the doctor who should temporarily decide to either wean down the dose or stop the TKI, or maybe change it to a second generation one or another one if they are not able to tolerate a first generation TKI, or vice versa. So it is very important that the patients do not stop the medication on their own. So again, we have talked about this, conditions in which dasatinib needs to be stopped. Basically, it's the cardiac conditions and the hypertension. Again, lung problems. If somebody has a pleural effusion, pulmonary hypertension, COPD, chronic smokers also. So such patients, we need to avoid dasatinib, and it is better to go for another alternative TKI. Next slide, please. I just wanted to summarize over here that change to an alternative TKI should be considered if there is a treatment failure on the first line of therapy, and whether it is documented. I mean, whether a 1 log reduction or a 2 log reduction or a 3 log reduction is not reached, whether these stipulated endpoints of time, 3 months, 6 months, 12 months, and the choice of the second generation therapy in resistant patients is initially guided by the BCR-ABL, kinetic KD mutation, the kinetic domain mutation analysis, and also dose escalation to 600 milligrams of imatinib per day is reasonable for patients with a suboptimal response, and who meet the warning criteria as per the ELN, by which I mean that there are telltale signs and that the drug is not working very well. And finally, in the absence of specific mutations, the patients pre-existing comorbidities and known side effect profiles of second generation TKI should inform treatment choice. So obviously, when you're deciding, it has to be on the basis of the side effect profile also. Now, next we talk about nilotinib versus imatinib. We were talking about dasatinib versus imatinib, and this is the NST&D trial. And over here, again, we see that compared to imatinib, which is the first generation TKI, nilotinib has a much better efficacy, by which I mean achievement of the major molecular response, or 3 log reduction is much higher with nilotinib. The trial used either 300 milligram of nilotinib twice, or 400 milligrams of nilotinib twice. So compared to 400 imatinib once daily. So we see both the blue arms, they have a much better, the curve is much higher compared to imatinib. So there is not much difference between whether we use a 300 or a 400. So slightly better response rate in patients in whom 400 BD of nilotinib was given. So that is the standard drug dose that we use these days, which is 400 milligrams of nilotinib BD. Next, please. Next slide. Okay. So bosutinib, well, this is not something we use very regularly, and we usually, I think, reserve it to as a third line TKI in patients who are refractory to or intolerant to multiple lines of at least 2 lines of TKI, including a first generation or a second generation one. Then we go on to bosutinib. But again, bosutinib has its own set of side effect profiles, and we have to be careful about using bosutinib again. So next slide. So this is not something we will talk about much in detail. So again, when bosutinib was compared to imatinib, and we were comparing the cell proliferation in both these drugs. So we see that obviously the cell proliferation is much lower when we use bosutinib compared to imatinib. So again, any day bosutinib is much better in patients who are resistant to imatinib. If we are thinking of not using nilotinib or dasatinib due to their own particular side effect profiles or patient contraindications, then I think we can consider bosutinib in patients in whom they have not achieved adequate response with imatinib. Next slide. Right. So again, the before 5-year update in which they compared the major molecular response or the MR3, MR4 or the deep molecular response, or MR4.5, which is the very deep molecular response outcomes with bosutinib versus imatinib in newly diagnosed CML-CP. I'm not going to be going into the figures of this. The crux of this slide is that achievement of all these particular milestones are much higher with bosutinib, which is a third generation TKI, compared to imatinib, which is a first generation TKI. Next slide. So again, similar data. Now, this particular slide shows, it basically compares bosutinib in patients who have received imatinib and dasatinib, and imatinib and dasatinib, either patients who are resistant or intolerant to dasatinib, or in patients with imatinib plus who have received nilotinib and they're resistant. So basically, patients who have received at least 2 lines of prior tyrosine kinase inhibitor therapy, including a first and second generation one. So their response in patients who have not achieved the milestones, or in which who are not tolerant or who are resistant to 2 lines of drugs, in such patients bosutinib can be used. And in such patients, again, we have quite a number of patients who have achieved the required molecular and cytogenetic milestones when bosutinib was introduced, although they do come with their own sets of side effect profile. And a few patients succumbed even when bosutinib, probably due to progression of the disease into accelerated or blast phase. Next slide. So current CML monitoring recommendations. So again, this is important, and I think we spoke about this a while ago, that we check whether every 3 months initially we check the patients and we see how much of log reduction is achieved, and 1 log reduction, or in which the BCR-ABL IS is less than 10%, and the major molecular response is when it is 3 log reduction or 0.1%, less than 0.1%, and when it is less than 0.001%, that is deep molecular response. So initially, before achievement of the major molecular response, we prefer monitoring patients every 3 months. So once we establish a major molecular response or a complete cytogenetic response, then we can relax a bit, and maybe then we can monitor BCR-ABL every 6 months. If MMR is observed, by which I mean BCR-ABL IS less than 0.1%, and if it is sustained, we may continue to monitor by RQ-PCR 6 monthly. However, if the MMR is lost or the RQ-PCR increases by 0.1 to 0.5 to 1, or loss of MMR, if the BCR-ABL increases by more than 0.1%, Then again, we need to go back to more frequent monitoring, which is 3 monthly. And again, if a patient was initially responding to a TKI and suddenly, they had achieved an MMR and then they lose an MMR, we need to always suspect whether there is a mutation which has been acquired. And so we need to do a mutation analysis, the T315I mutation. So that is important. Then we change therapy. Once we have a loss of complete cytogenetic response or the MMR is lost, if a patient had initially been on a first generation, we switch to a second generation. And obviously, simultaneously, we do a mutation testing. Next slide. Next slide. So what are the predictors of long-term outcome of second generation TKIs? So basically, it is very, it is simple. It's just two things: achievement of complete cytogenetic response and a major molecular response. If a patient has achieved a complete cytogenetic response and a major molecular response, it is much more likely that such patients will have a much higher event-free survival and overall survival compared to patients who have not achieved CCYR and MMR. Next. Okay, so ponatinib. Now, ponatinib is something which is, it is again a third line TKI and it is not available in the Indian market. And it is basically given to patients who are resistant to more than one lines of tyrosine kinase inhibitors and patients who have acquired a T315I mutation. So ponatinib is given basically for such patients, and the data shows that patients receiving ponatinib who are having a mutation are the ones who are the most to benefit from ponatinib rather than patients who are intolerant or resistant to another TKI. Next slide. So I think we can skip this one since we are not using ponatinib in the Indian market. All right. So asciminib, again, like I said, this is still under trial and a lot of studies are still going on regarding the asciminib. But the ASSEMBLE study is being done and it directly compares asciminib to bosutinib and for the determination of the major molecular response at 24 weeks and at 96 weeks. So patients were divided into the group that received asciminib 40 milligram BD and bosutinib 500 milligram once daily, and they were compared directly. So what the study shows is that, next slide please, that patients receiving asciminib are found to have more patients who got asciminib achieved an MMR compared to bosutinib. So asciminib is found to, as per this trial, till date, the ASSEMBLE trial, asciminib is more efficacious compared to bosutinib, and in terms of achieving a major molecular response at 48 weeks. And again, the BCR-ABL IS percentage less than 1% has been the more number of patients, 42.3 achieved this in stipulated time compared to bosutinib. So the outcome shows that asciminib is more efficacious compared to bosutinib. Next slide. So this is just shows that it is a comparative slide which shows the efficacy of third generation tyrosine kinase inhibitors for achieving complete cytogenetic response in CML. So patients who have already received prior 2 lines of therapy, and we see in these slides that ponatinib probably works best compared to bosutinib or nilotinib in patients who have already received imatinib and dasatinib. And again, patients who have received already 2 lines with imatinib and nilotinib, in such patients, ponatinib again works best compared to whether dasatinib is given or bosutinib is given. Okay, so this is the last slide of our presentation. And what I would like to emphasize over here is that, again, when we have a patient who is suspected to have a CML, so along with definitely diagnosing the patient, it is very important to address other issues. One we already mentioned is the oncofertility issue. In younger patients, that is something we need to take in mind. We need to be very careful about choosing which patients to go for a second generation. And when family planning is concerned, it is very important to address the other side effects of the disease. For example, anemia. And such patients, obviously, when they have very high counts, they are very prone to developing thrombosis and hyperviscosity also. And obviously, because this is a primarily a hematological condition, development of infections and pain management sometimes because of infarction of the long bones and because of leukostasis. So these things have to be maintained over here. These things have to be addressed. Supportive care is as important as giving a tyrosine kinase inhibitor therapy. Maybe you would need to introduce a hydroxyurea, which is a cytoreductive therapy. Maybe you would need to do an urgent leukapheresis in patients with very high WBC count and having hyperviscosity syndrome. Address the issue of anemia. If the patients are iron deficient or vitamin deficient, do give those supplements. And if the patient is at a very high risk of thrombosis, do give some anticoagulants. And of course, address the pain issue also. Then I think patient choice over here too plays an important role. And they should get to choose which kind of therapy they want to undergo and whether they want to undergo a first generation or second generation one. Obviously, after informed, after we have informed all the side effect profiles and the benefits and risks of everything. So, and patients should undergo a very holistic care, not just that every 3 monthly we call them and then we do the RT-PCR, RQ-PCR, and then we continue the tyrosine kinase inhibitor. I think it is important that every patient undergoes a very holistic approach over here. We address the psychological issues also, because after all, this is hematological malignancy. No matter if it is a chronic one, then the patients are getting chemotherapy, even though it is just an oral chemotherapy. So psychosocial issues too have to be addressed along with an overall holistic approach over here. Similarly, patients ending up with an accelerated phase or a blast crisis phase, they have to be counseled properly regarding the prognosis of the disease and what options we have in hand regarding the allogenic stem cell transplant, the mortality rates, and the donor, what the available options we have in terms of donor, whether it is a sibling donor or a matched unrelated donor. So I think these are everything we need to consider whenever we have a patient on CML, and not just the tyrosine kinase inhibitor therapy. Thank you. I would like to, I'll be happy to take up any questions that you have.
Thank you, Dr. Amrita. It was indeed a detailed explanation, and you went on. I think it took almost like around 1.5 hours. It was too short a time for you to just cover up the whole topic, and it was really very wonderfully done.
Thank you. Thank you.
And we have a couple of questions which has really come in. I'll just try and ask you. First thing is, what percentage of people go into the accelerated phase if they start on the first line treatment, and in how much time it will go? Right from the first phase to the last phase.
Okay, so usually patients who are already on first line therapy, and if they are doing regular follow-ups, we should ideally not see any patients going to the blast crisis phase. Was the question on accelerated phase or the blast crisis phase?
So basically, they wanted to know if from starting the first phase to the last phase, what is the percentage of people who get into that second last phase?
Okay, the last phase. So if the patients are following with you on a regular basis, we call the patients every 3 months. If you have started imatinib and after 3 months we see that they have not achieved the particular milestone, I think it is better to increase the monitoring of the patient and maybe switch to a second generation, or maybe wait for 6 months. As doctors, we should not let a patient who progress from a CP to a BC if the patient is under monitoring. Most of the patients who come with a blast crisis phase are the patients who have either defaulted treatment or they have not been treated at all. So ideally, there should be no patient under supervision or under treatment progressing from the first stage to the last stage. We should intervene in between. That is why we follow patients every 3 months.
And we have got one more question from Dr. Rajiv Kumar Jain. He says that, what are the options for joining the clinical trials for CML patients, and how long the option is exercised, and is it safe actually for the patients to get into this trials actually?
Options for joining clinical trials for CML patients and how the options are to be exercised. Well, options are pretty safe. So basically, all the trials that we're doing is by tyrosine kinase inhibitors now. And whatever trial we have seen till date, So, well, the data, the huge amount of data that we have comparing second generation TKIs and third generation to first generation is because of clinical trials. So I think it is safe that the patients do undergo clinical trials. We have these newer molecules coming up asciminib. So until and unless they are under direct supervisions and we monitor the mutation status and the BCR-ABL status and the Philadelphia chromosome status, I think it is definitely safe to undergo trials, and it should be encouraged. In the Western countries, if you look at UK and US, all the patients who initially are diagnosed with a CML, majority of them end up with trials. Patients who refuse trials go for conventional therapy.
Indeed good, actually. But one thing what you have noticed is probably patients, when they come to you, they know that, it's a common terminology, what they call it as blood cancer, what they call. So they are totally distorted. In fact, they're totally, their mind balance is really off. Is there any sort of a counseling what we really take in actually just before we start out a treatment for that? Because unless the mind is good enough, the treatment really doesn't work. That's what we always feel. What's your take on that?
Absolutely, Dr. Absolutely, sir. You're very right, which is why I emphasized the importance of a holistic management and addressing the psychosocial issues, because patients do not understand the difference between a chronic leukemia and an acute leukemia. They just understand leukemia as blood cancer. What we need to tell them is CML is something which is very easily treatable. You do not need to get admitted to the hospital. You do not need to undergo chemotherapy. Staying admitted is just an oral drug. You need to stay at home and take it, but you need to be very, very compliant. Otherwise, you will end up in a condition in which you will need admission and intravenous chemotherapy. So we need to, I think, emphasize to the patients, the good prognosis of a patients having and coming with a CML in a CP, and obviously, how good the oral chemotherapy works, the tyrosine kinase inhibitors work. So although this is a chronic leukemia, it is a leukemia, this is a chronic one, and this bears a much, much better prognosis compared to the acute ones. So that thing has to be explained to the patient. And also we need to explain the major risk associated with stopping the medication. Sometimes patients, when they hear this is a chronic leukemia and when we explain it to them, they kind of become very complacent. And then they have side effects, they just stop it on its own. So along with reassuring the patient, I think we need to be very firm in telling them, in reaffirming them that this is leukemia nevertheless, and treatment, it is the doctor who should be stopping the treatment and not you.
It's indeed actually good. Just wanted to know, is there any insurance agents who can really support this treatment? Because a lot of people really feel that, insurance are needed. But in Indian scenario, a lot of insurance are really not taken across. But is there any insurance for this actually coverage?
Oh, I don't think so. I think that's a very good question that you asked. But major of the insurance which is covered is for patients who are admitted to the hospital and who undergo therapy once they are admitted to the ward. Since this is an oral therapy and you take it on when you're at home, no, insurance doesn't cover it. But I think the drug companies, they do have some very good patient program schemes going on, and they are there for patient support. So they have schemes as in they get some supplementary strips along with some particular strips they take, or maybe decrease the price of the medication. So I think there's no insurance, but we have patient program schemes as far as the drug companies are concerned.
I think Mr. Vinod Gupta has really asked again question: do the patient with desnobide as a first line go to the accelerated phase? If the patient is taking that drug as a first line, does he get into the last phase of?
Yes, very much possible. So, like I said, not all patients respond to even second line TKI. So, if somebody has a high SOCAL score and you decide to start the patient on dasatinib, they can very well end up going into an accelerated phase if they don't respond to dasatinib. So, in that case, maybe we need to check for the TKD mutation, or we need to you can try and change the patient to nilotinib, something which has not been done. But obviously, first generation ones won't work in such case. You have to go second generation and higher. So if the dasatinib doesn't work, and not necessarily that all patients with accelerated phase will have a lymphoid blast, they can be a myeloid blast also, right? So even patients on dasatinib, although very, very less percentage, can end up having getting into an accelerated phase. In that, I think the most important thing to do in that such patients is check for the KD mutation and maybe introduce another line if necessary, or sometimes increase the dose of dasatinib. You can try and do that and see if the patient responds.
Is there any percentage to that? In a sense, certain percentage get into that?
Not that I'm really aware of. I think very few patients. But initially, we give like 100 milligram of dasatinib. If we have a patient accelerating to, on dasatinib, we can, well, the dose of dasatinib on AP is 140 milligram daily. We can give a trial of 140 milligram daily and see if that works, along with obviously doing the TKI mutation.
Thank you, doctor. I think there are no more questions. I think it's time for us to really thank the Delhi chapter, Dr. Rajendra Kumar sir, and everyone, Dr. Rajiv Kumar Jain sir, who has really given us the opportunity to be here. And I would just thank Dr. Amrita for really, taking the time out and just coming out in this conference and just trying to tell us a lot about the AMLs, and we really enjoyed it. Actually, CMLs, actually, we really enjoyed it. Thank you, doctor, for your wonderful lecture on that. I just hand over to the organizers to take it forward.
Thank you so much for having me here. It was a pleasure.
Sir, we can conclude, sir.
We can conclude. Okay. I would just like to thank each and every delegate who have been logged in their busy schedule, and it is something like out of schedule on a Saturday evening, and probably sitting out and listening to madam. Actually, she was really wonderful in explaining very detailed, right from the phases, right from the treatment, right from the side effects of all the things, and what are the how to monitor them. Everything was really explained beautifully. Thanks for that, and I really want to thank the NOH for this digital connect and probably enlightening us and probably knowing more about this. Thank you so much for all. Good night.
Thank you. Thank you so much. Appreciate it. Thank you.
Thank you.